Okay, let's continue with this decerebrate and decorticate posture. Here, in decerebrate posture, we have seen due damage to the upper brainstem, damage to the upper brainstem, and arms are adducted. Here also, arms are adducted. Here, arms are extended. In case of decerebrate, it is extended, but here it is flexed. And in decerebrate, again, the wrists are pronated and fingers are flexed. And here you can see in decorticate, regarding the wrist and fingers, these all are flexed but towards the chest. The arms will be to the chest, that is in decorticate. And in case of legs, in decerebrate posture, the legs are stiffly extended. Legs are stiffly extended. You can see the same posture in decorticate. The legs are stiffly extended, the same. But here in decerebrate, with the plantar flexion of the feet, here the internally rotated with the plantar flexion of the feet. Plantar flexion is common in both posture, but in case of decorticate, there will be internal rotation to the legs. So these two pictures and these two position you have to always keeping in mind, decerebrate posture and decorticate posture. Then the next one is opisthotonous position. Opisthotonous means this is whenever you heard the word opisthotonous means you had to make a picture in your mind that is an ex extremely extended, that is an hyper extended body. In movies such as in supernatural movies and all, you may see this position. I am sure. So, for example, this kind of position we can see in some of the supernatural films and all. So this is a hyperextension of the entire body. This is the basic of opisthotonous position. So state of severe hyperextension and spasticity in which an individual's head, neck and the spinal column enter into a complete bridging or arching position. And the patient's head, neck as well as the spinal column, this will be coming into an arch. Okay, this is the hyperextension. We can call medically this is known as opisthotonous position. So decerebrate, decorticate as well as opisthotonous you have to keeping in mind this and the cushion triad. In the previous slide we have seen cushion triad. These four, I hope this will be a new vocabulary, new word for you. Clear. Now, generally, in a single view, we can see if the person is having an increased intracranial pressure means there will be changes in loss of consciousness. Eyes will show some of the changes like papilledema, pupillary changes, impaired eye movement, etc. Then posturing, we have seen decerebrate, decorticate, flaccid means opisthotonous. Then decreased motor function here, changes in motor ability, posturing, etc. Patient will be having a headache, seizures will be the changes in vital signs that there we have to keeping in mind regarding the cushion triad. Then vomiting will be projectile vomiting, changes in speech because entire brain higher function is getting altered, obviously speech may go. In case of infants, just to understand, in case of infants, the bulging fontanelles will be there, cranial suture separation may happen, head circumference will be increasing or it will be more, then high pitched cry will be there. This is regarding the infants, that is small children. You have to keeping in mind regarding the major changes in an adult that may happen due to increased ICP. Hope you are able to follow these points clear. Now let's move on to some of the complications. When this condition is worsening, the patient may develop brainstem herniation, diabetes insipidus, syndrome of inappropriate antidiuretic hormone. That is, this ADH hormone will be secreting more uncontrollably, more production will be there. Then the patient may develop seizures, stroke. Eventually, the patient may ends up with death. And here we can see a word that is brainstem herniation. Brainstem herniation means nothing but here uh, simple thing you have to keeping in mind, some of the parts of the brain or the cerebrum, it can be cerebrum, cerebellum, anything, the parts of the brain will be getting bulged out. This is just what we are calling as herniation in a medical term. So this bulging of the brain tissue it can be either cerebrum, cerebellum, or any brainstem or the any part. This can be bulged out, and this can be again classified based on the area or the location of the bulging as tentorial herniation, uncal herniation, and cingulate herniation. In case of tentorial herniation, here the mass lesion in the cerebrum. In the cerebrum, the lesion will be in the cerebrum, and this will forces the brain to herniate downward through the opening created by the brainstem. That is in the for there is an opening for brainstem to be and to view as a continuation of this spinal cord. There is an opening for this brainstem. So through that downward opening, the lesion present in the cerebrum will be forces the tissue towards this brainstem, and that is known as the tentorial herniation. Now we are having uncal herniation. This is lateral as well as the downward herniation. Downward herniation, that is towards the lowest part along with lateral part. Lateral area also is getting bulgy, that is uncal. Now cingulate herniation. Cingulate herniation means it occurs when there is lateral displacement of the brain tissue beneath the fourth cerebri. That is the if the entire brain tissue is getting displaced to the lateral part, means lateral bulging will be occurring. This is known as a cingulate herniation. Here the entire brain tissue is getting displaced. That is the basic difference between the tentorial, uncal as well as the cingulate. And if you are having any textbook of medical surgery like Lewis, Brunner, you can clearly, or even in net Google also, you can see some of the pictures that is clearly showing how this brain or the tissue is getting herniated or bulging through the stem lateral wise, and so you should have a focus to the textbook also, then only you can keeping in mind in a clear. So this is regarding the brainstem herniation. Now let's have some of the diagnostic studies how we could able to diagnose this increased ICP or the cerebral edema. Of course, history collection and physical examination. In case of physical examination, what we have to focus more is that neurological examination. Then computer tomography, that is CT and a CT scan, as well as we have MRI scan. And in previously, I have already said that in case of brain as well as a spinal cord, the most good imaging test is MRI. MRI is very it is one of the advanced form, as well as it will be giving completely reliable results in case of brain as well as spinal cord. Then electroencephalogram (EEG). The electrical nerve signals alterations can be identified through this electroencephalogram. Then positron emission tomography, PET, PET scan. That is to identify any intracranial space occupying lesions like tumors or any abscess, etc. So that in order to identify that, we will be doing PET scan. Then measurement of ICP, lumbar puncture. Now, measurement of ICP means we have to definitely measure this ICP. That is by some of the invasive procedures like ventriculostomy and all. Then here we are having another one, lumbar puncture. Lumbar puncture I have added here only because you have to keeping in mind whenever there is continuously increasing this um, uh, intracranial pressure, means we should not do the lumbar puncture in the later stages, because this may again cause CSF drainage leakage, and then again it may cause increase in ICP. Okay, so when we are confirmed with the sustained increase in ICP, we should not do the lumbar puncture. Clear? So we can see detail. ICP should be monitored in patients admitted with a GCS score of 8 or less and an abnormal CT or MRI. When we have to measure this ICP, if the person is having GCS score of less than or equal to 8, or a CT or MRI is showing any abnormal features, means we can measure the ICP.